My name is Christina Chambers, and I'm in the Department of Pediatrics at the University of California, San Diego, in the Division of Dysmorphology, Teratology. Member of the Teratology Society and the Organization of Teratology Information Specialists. And we're pleased to welcome you today to this webinar sponsored by the Teratology Society and the Organization of Teratology Information Specialists, or OTIS, on the Fetal Alcohol Syndrome. The presenter this morning is Dr. Kenneth Lyons Jones, who I'm sure most of you in the webinar know who is a distinguished professor in the Department of Pediatrics at University of California, San Diego, and who is responsible for being one of the first people to identify the fetal alcohol syndrome, and certainly as a leader in this field for the past 40 years. So just a little bit of the logistics. Dr. Jones is going to give his presentation, and those, I think most of you will be submitting questions and answers via web rather than by telephone, but if you are connected by telephone, you can ask questions that way. Via the web, you can raise the hand icon, and I will see the questions, and I will repeat the questions to Dr. Jones, and he can respond to them in audio. We are very pleased to have you all with us here today, and I think this webinar is going to be recorded for later viewing as well. So I pass this on and introduce Dr. Jones to present a retrospective look at 40 years of FASD.
So thanks, Tina. And as Tina says, I'm going to take you through a retrospective look at 40 years of the fetal alcohol syndrome or fetal alcohol spectrum disorder here over the next 45 minutes to an hour. And I'm going to break my talk into three parts. The first is I'm going to talk about the recognition of this disorder. Thereafter, I'm going to talk about the reaction to that recognition, which surprised me to a very great extent. I'll go into that as we go forward with this, but it really sort of surprised me how people reacted to it and how they still are reacting to it. And then I'm going to talk a little bit about the present, and I'm going to go into some things about the future as far as I'm concerned, as far as this condition is concerned as well. And I'm calling that the resurgence, and I'm calling it the resurgence not because I think that we figured this condition out, not by a long shot, but I think that after many years in this study, in this condition, that we finally sort of got the ship turned around in the right direction, and we're asking the right questions, and so we're starting to get some answers that I think are really relevant about this disorder. So let's move right to the recognition of this disorder, and the recognition of this disorder was based upon the work of Dr. David W. Smith, who was a professor of pediatrics at the University of Washington in Seattle, Washington, and from 1972 to 1974, I was lucky enough to be a fellow with him. So in the early February of 1973, Dave Smith was called down to the King County Hospital to see a group of babies who had been born to chronic alcoholic women. So, as it turned out, a pediatric resident at the University of Washington by the name of Christy Uleland had been on call one night at the King County Hospital, which is now called Harborview Medical Center in Seattle, and a obstetric resident came up to her and said, "Christy, what do you know about babies born to chronic alcoholic women?" And she said, "Nothing. Why do you ask?" And he said, "Well, I'm about to deliver such a baby, so you better find out everything you can find out." So Christy raced down the steps across the street into the library, where she looked everything that she could find on babies born to alcoholic women and prenatal alcohol exposure. And in fact, what she found in Wilson's textbook, or Williams' textbook of obstetrics, which at least at that time was the major textbook in obstetrics, was that alcohol probably was not bad for the baby, maybe even good. So she sort of snickered and ran back upstairs, and the two of them, the obstetric resident, she went in to deliver this baby, who clearly was small for gestational age with respect to length and weight, and was also microcephalic. So Cree became very interested in this, and over the next 3 or 4 years, she was able to ascertain 10 or 12 children, all of whom had been born to alcoholic women. And then Christy went out into the practice of pediatrics in the Seattle community, and she turned these kids over to Dr. Shirley Anderson, who was then head of the outpatient clinic at King County Hospital, the pediatric outpatient clinic. And Shirley evaluated these kids and thought that in addition to being small, and in addition to being microcephalic, and in addition to be intellectually disabled, that they also seemed to have some unusual features about them. And so she called Dave on the phone this morning, in early spring of '73, and had to come down and take a look at these kids. And I was Dave's fellow, so I got in the car with him and trailed after him down to see these kids. And when we walked into the outpatient department, these 8 children, along with their caretakers, were sitting in this single room, and we went from one to the other. And 4 of these children, who you see on this next slide, really looked alike, with this smooth philtrum that you can see, particularly in the top kids, 2 children there, with this thin vermilion border of their upper lip, and they had these short palpebral fissures, these features that now have become characteristic of the fetal alcohol syndrome. The other 4 children were all intellectually disabled and were short and underweight, but they did not have the physical features. So we got back into Dave's car to go back to his office at the University of Washington. The first thing he said to me was, "Well, Ken, what do you think about this?" And I said, "Not much, Dave. What do you think?" And he said, "Well, this is clearly the most important thing that I've ever seen, and I suspect it is the most important thing you will ever see as well." And of course, he was right. So we got back to his office, and we looked in his unknown file, which were large numbers of children who he had seen over the years, who he didn't know what they had. And so what we looked for in those unknown files was the 3 features that we had thought most characteristic about these 4 children that we just seen, who were born alcoholic women. And 2 children's charts fell out, and when we went back to look at the mother's charts, those 2 mothers were both alcoholic. So here in about 2.5 hours that morning in February, we had seen 6 kids, all of whom looked alike, all of whom were born to mothers that drank heavily during their pregnancy. Well, the next week, Dave went to Toledo, Ohio, to be a visiting professor, and he asked the chief resident if he had seen any children who had been born to alcoholic women, and he said, "As a matter of fact, I have," and he got the mother to bring the child in, and the child was really a dead ringer for these 4 kids, or these 6 kids that we've seen. And while he was away, I got called over to the Children's Orthopedic Hospital to see a little girl who had a congenital hip dislocation, and she had the same clinical features and was born as well to a chronic alcoholic woman. So here in about 2 weeks, we had seen these 8 kids. So the recognition of this disorder was very, very quick. And this is the pattern of malformation, and this is the only slide I'm going to show you about the pattern of malformation, because I think most of you are probably aware of that. So these kids have growth deficiency, with both prenatal growth deficiency and postnatal growth deficiency. They have microcephaly, so their heads are small. They have problems in terms of performance, and they have these very typical facial features, including these short palpebral fissures, this long, smooth philtrum, and the thin vermilion border of their upper lip. And you see here on the next slide a child with this condition who is so characteristic of it, with that long, smooth philtrum and the smooth, thin vermilion border of the upper lip. And although you can probably see that this really short palpebral fissures as well. Well, about a week after we had seen these children, these 8 children, Dave said to me, "Look, we need to get a psychologist to evaluate these kids as well, because clearly that seems to be a major feature of this intellectual disability." So I went out and met with a person in the Department of Psychiatry at the University of Washington and asked him if he knew a psychologist that might be able to evaluate these children. He said, I've got just the person for you, and that's this lady who I'm showing you on the slide, who's Ann Pickowitz-Streisguth, who is a neuropsychologist who was in the Department of Psychiatry at the University of Washington and evaluated these 8 children, and I'm going to show you very briefly what she found in a second, but I do want to stop and say that Ann Streisguth has probably made a greater contribution, or certainly as great a contribution to this condition as anybody in the world over the years. And this is the table from the first paper that was published on this disorder in The Lancet in 1973, and it shows you the mental, motor, and social development of these 8 kids, and you can see that they really were quite severely affected. Oh, I want to point out, as you see the second to the last thing there, the IQ or MDI, mental developmental index, that these children's mental IQ or MDI went from below 50, but only 1, to a high of 83. So these, for the most part, are not severely intellectually disabled kids. These children, for the most part, have mild problems in terms of intellectual development. So that was the recognition of this disorder. As I say, it took about 2.5, 3 weeks, and it was a very exciting time for us in Seattle. Then came the reaction to this, and as I said to start with, the reaction to this was really a surprise to me. So this the initial reaction was disbelief, as you see here on the top of this slide. I gave a talk. Dave was very aggressive in terms of getting us in a position to talk about this condition, and I gave a talk at the plenary session of the APS-SPR meeting in San Francisco that April or May. And the second I finished talking, I will tell you I was scared to death to start with, but the minute I finished talking, hands went up all over the audience, and everybody didn't believe a word said, and they all thought it was due to an intrauterine viral infection and a variety of other issues. And of course, the issue was that if people had been drinking alcohol for years, for centuries, and if this was real, somebody would have identified it before. And of course, they identified it before. It's just that people really didn't take notice of it. It was written about in the Bible and far more places, and it was written out in Brave New Worlds and by Huxley, and Hemingway wrote about it. Just for the fun of it, I'll read you from Brave New Worlds by Aldous Huxley. 2 people are talking, and they say that Fanny said, "He's so ugly," said Fanny, "but I rather like his looks. And then so small." Fanny made a grimace. "Smallness was so horribly and typically low caste. I think that's rather sweet," said Lenina. "One feels one would like to pet him, like a cat." Fanny was shocked. Somebody made a mistake when he was still in the bottle. Thought he's a gamma and put alcohol into his blood surrogate. That's why he's so stunted. So this disbelief was real, and we could understand the disbelief, but people had thought this and written about it before. And then after the disbelief calmed down, it didn't go away, but calmed down, there were a number of people throughout the world who rigorously delineated a recognizable pattern of human malformation and added to the things that we had come up with in terms of the clinical features of this disorder. And then in 2000, Armstrong and Abel wrote a paper, Alcohol and Alcoholism, in which they first suggested that that the fetal alcohol syndrome had developed into a social problem. And of course, social problem occurs when activities rise to a level in which someone or some group attributes harm to those activities, calling the government to stop them, and can convince others of that view. So poverty is clearly a social problem. But then Armstrong and Abel, I think, went a little too far, because they then suggested in that same article that fetal alcohol syndrome had developed, or at least society's response to the fetal alcohol syndrome had led to a moral panic, which is defined as an alleged breakdown in public morality, a heightened level of public concern, a distortion of ideology, and certainly the burning of witches at the stake in 1544 was clearly a perfect example of a moral panic. It was really mass behavior, mass hysteria, leading to moral panic. So it's sort of interesting. Well, first of all, I would just say that whereas I think that Armstrong and Abel were correct, that this disorder had evolved into a social problem, I think it's going a little bit too far to consider that this had developed into a moral panic. But it really is interesting the way this disorder started out as a purely medical problem, and then it evolved over time into a social problem, which I think is really a very fascinating observation, and I think is true. So let me say a few words about why I think this happened. So the 60s were really a very unique time, as I think everybody in this room, or not in this room, but that's listening here, recognize. It was Woodstock, as you see up there on the left. It was free love. It was really acceptance of everything. And it was the dawning of the age of Aquarius. So you see here, when the moon is in the 7th house and Jupiter aligns with Mars, then peace shall guide the planets and love will steer the stars. This is the dawning of the age of Aquarius. And understanding, sympathy and trust abounding, no more forces of derision, golden living dreams of vision, mystic crystallizations and the mind's true liberation. On the heels of the age of Aquarius, I think to a great extent as a backlash to it, came the new temperance movement in the 1970s and the 1980s, and I think you'll all remember that there was in the 1850s an original temperance movement. You see down there, lips that touch liquor shall not touch ours. But in addition to that, in the 70s and 80s, a new temperance movement was born. And you see here advertising, sin and sickness, the politics of alcohol and tobacco, marketing, and soon thereafter, Ronald Reagan was elected President of the United States. So, sandwiched between these three events, the Fetal Alcohol Syndrome was recognized in 1973, and then, at least in the United States, in 1973. And then, in 1980 came the birth of MAD, or Mothers Against Drivers, which I think that most of us would agree is perhaps the most effective lobbying group that there has ever been. And I would suggest, as others have as well, that the way society responded to the fetal alcohol syndrome was hauntingly similar to Mothers Against Drunk Drivers. There's a paper that was written by Craig Reinerman in 1988, which he suggests that determination that a social problem exists depends on the interaction of two factors. The first factor is the credibility of the claims makers, and as far as MAD was concerned, the credibility of the claims makers is unquestionable. The death of a child at the hands of drunk drivers. Children had been dying at the hands of drivers for years, and really nobody was able to get at this in the same kind of effective way that MAD was until that time. And as Reinerman suggests, it required really a second factor, and that second factor is the historical context within which the claims are being made. MAD was in agreement with the morality of the post-Woodstock era, the policy ideologies and social control strategies of the Reagan administration, the new temperance movement, and resurgent right. MAD's beginnings lie in victims' rights movements, which seek punishment of criminals. The name of the organization ends with drunk drivers rather than drunk driving. The name MAD conjures up moral anger, and the organization was based on individual responsibility for one's actions. So as I said, I see great similarity between this and the way people responded to the fetal alcohol syndrome. In the case of FAS, the credibility of the claims makers is also unquestionable. A baby with birth defects and retardation whose mothers drank heavily during her pregnancy. Evidence had been available, as I pointed out, for years, indicating that drinking alcohol during pregnancy led to serious problems in fetal development. And I will tell you, the first time, at least soon after this disorder was recognized, that I became aware of this was at the Second International Birth Defects meetings in Vienna, Austria, and I gave a talk about this, and soon after my talk, Dr. Lenz, who's the individual who's responsible for the identification that thalidomide was a serious teratogen, came up to me and he said, Ken, you and Dave Smith, I really think this is very important what you, the two of you have identified, but I have to tell you that you were not the first people to identify this. I went to a pediatric meeting in France in 1968, and we'll never forget the presentation that a pediatrician in France by the name of Paul Lemoine gave, in which he really described just what you have been thinking about. So why don't you write Paul Lemoine? So I went back to Seattle and wrote Paul Lemoine, and he wrote me back, I thank you very much for the two publications which you sent to me on the subject of malformation and anomalies which you have discovered in infants of alcoholic mothers. I'm sending you a photocopy of the publication which I gave in 1968 at the Society of Pediatrics of the West, and also the bibliography of the thesis of my student on the subject. Your publications have very much interested me because they point out exactly the same anomalies which we observed in a number of cases in regards to their faces, their undergrowth, and the existence of malformations, particularly of the soft palate, the heart, and the bones. But these facts are again presently barely admitted by my colleagues in France, which very much astonishes me. I know well that I live in an area that is unhappily very affected by alcoholism. Kindest personal regards, Paul Lemoine. So, clearly, 1968, the historical context was not right, in France at least. But in 1973, they were. Fetal alcohol syndrome was also in agreement with the reality of the post-Woodstock era, the policy ideologies and social control strategies of the Reagan administration, the new temperance movement, and the resurgent right. The restoration of FAS also occurred during the time of the victims' rights movements, which seek punishment of criminals, in this case the alcohol-consuming mother. Unfortunately, that approach not only does not help the alcohol-consuming mother, but it does not help the real victim, which of course is the affected child. So now I want to move and talk about the resurgence. So I'm going to talk a little bit about the present, and I'm going to talk a little bit more about the future, and that's what I'm going to spend the rest of my time talking about. I think that this resurgence really began in 1996 with the Institute of Medicine report, and I'm showing you here on the next slide what the Institute of Medicine came up with on their report about the fetal alcohol syndrome. And they were the first group that wrote down on paper and indicated that prenatal exposure to alcohol causes not just the fetal alcohol syndrome, but causes a spectrum of defects. So at one end of that spectrum is the fetal alcohol syndrome with confirmed maternal alcohol exposure. But at the more, I shouldn't say more mild end, but at the other end of the spectrum is alcohol-related neurodevelopmental disorder, or ARND. And that is a condition in which the children have serious neurobehavioral problems, but do not have the physical features of the fetal alcohol syndrome. And in between those two is partial fetal alcohol syndrome and alcohol-related birth defects. So out of this concept that was this spectrum of defects came the term fetal alcohol spectrum disorder. And it really changed the whole lay of the land as far as prenatal alcohol exposure was concerned, because it allowed us to make a diagnosis of this disorder without the physical features, and to be able to then get the children into early support programs and get them involved in programs that would help them from a very early age. So while the framers Institute of Medicine report did a phenomenal job in terms of laying out this spectrum and pointing out this spectrum, they really did a lousy job in terms of defining in any kind of a specific way alcohol-related neurodevelopmental disorder. We were actually at that time desperate for a neurobehavioral phenotype for this disorder. We clearly had this clinical phenotype, but did not have a neurobehavioral phenotype. So if a child came in to see you who had neurobehavioral problems, no other physical features, you heard that maybe this mother drank during her pregnancy. This was so frequently an adoptive family or a foster family, and they said, well, we think that the mother drank during pregnancy, but really not sure. What we needed was a neurobehavioral phenotype that would allow us to say, based on that neurobehavioral phenotype, that this child was or was not affected by alcohol, and R&D did not provide that. The Institute of Medicine, the framers of the Institute of Medicine report really did not do a good job as far as that's concerned, and we are still suffering from that today. So despite that, in 1997, this paper by Sampson et al. In Teratology was the first paper that really looked at this disorder in a broad way and looked at this full spectrum and operationalized, if you will, for the first time, the Institute of Medicine report. So it was a population-based study in Seattle, Washington. It measured the rate of FAS at 3.1 per thousand. The full spectrum of fetal alcohol spectrum disorder was measured to be 9.1 per thousand, or 3 to 9 times greater than the rate of FAS alone. The rate of FAS and ARND was thus almost 1 every 100 live percent. I would point out to you, as you I'm sure all are aware, this is just about the same rate autism spectrum disorder, and you all, I know, are aware of the fact that autism spectrum disorder is getting so much press and through the medical profession, et cetera, and so much money for research and everything and clinical care. I understand that, and I think it's really important and great that they are getting it, but we need to get that as well for children who have FASD, which is really just as common and just as devastating a problem for the children who are affected with it. All right, so what I'm going to do now is go over some questions that I think need to be answered regarding the prenatal effects of alcohol as of June 2015, so right now, and I want to start off with a definition of ARND, and I'm going to start off that definition by throwing in a new term. And the new term is alcohol-related neurodevelopmental disorder, which is a new clarifying term. It's sort of abbreviated like AS is abbreviation for fetal alcohol syndrome as NDPAE. It's intended to encompass the full range of neurodevelopmental disabilities that can be associated with exposure to alcohol, and it's now been included in the DSM-5, which will then allow psychiatrists and psychologists to make a diagnosis of this. Whereas a diagnosis of NDPAE can be given in the presence or absence of physical features, R&D is only given if there are no physical features. Although not a specific category, NDPAE can be found under other specified neurodevelopmental disorders and can be coded as such in the patient's record. And the specific developmental disabilities are specified in the appendix, and the categories the proposed criteria are listed here on this slide. And you can sort of see that we're getting, from my perspective, we're getting to a neurobehavioral phenotype. We're not there yet, I don't think. At least the psychologists that have come up with this have assured me that we're not quite there. But I'm quite optimistic that we're getting close to a neurobehavioral phenotype. So just briefly to go through it, number one is more than minimal exposure to alcohol during gestation, including prior to pregnancy recognition. Not very specific definition of how much alcohol a woman should be drinking in order to qualify for this, but it's now sort of people focusing on the fact that 13 drinks a month at any time during the pregnancy, so just 13 drinks in 1 month is sufficient for this criteria. And for the first 4 weeks of pregnancy, so the first 1 month of pregnancy, a woman doesn't even know she's pregnant. and so she behaves like she wasn't pregnant, and it wouldn't be hard to create a scenario whereby she would be drinking 13 drinks in that first month, if not other months during the pregnancy. Then number 2 is impaired neurocognitive functioning. Number 3 is impaired self-regulation. Number 4, impairment in adaptive functioning. And I would just point out that impaired neurocognitive functioning does not necessarily mean an IQ less than 70. There are a number of other things because, in fact, there are a number of children with this disorder who, in fact, do have IQs within the normal range. And so that is not the only thing that gets you impaired neurocognitive functioning. And onset of the disorder must occur in childhood. There is clinically significant distress, there must be, or impairment in social, academic, occupational, other important areas of function. Now, 7 is that disorders should not be better explained by direct physiological effects associated with postnatal use of substance, a general medical condition, a condition, and 4 is another known teratogen. So the question then becomes, does NDPAE, or neurobehavioral disorder associated with prenatal alcohol exposure, equal alcohol-related neurodevelopmental disorder, or ARND? And I think the answer at this point is almost, but not completely. So ARND does not yet have agreed upon criteria, where NDPAE does. The behavioral mental health effects of prenatal alcohol exposure occur with and without structural features of FAS, and a child could have FAS and NDPAE, but not FAS and ARND. So I think we're close to coming up with a neurobehavioral phenotype for this disorder. I think we are close to being able to come up with a diagnosis, if you will, or a phenotype, if you will, for ARND, but I've been persuaded that we're not quite there yet. So the second thing that I want to talk about, or the second issue that I want to bring up, is the critical timing of exposure in humans. And you're probably all aware of the fact that Kathy Sulik and her group have reported for many years that the facial features of this disorder occur in the mouse at gestational day 7, which is the third to the beginning of the 4th week of human pregnancy. So Feldman from our group in 2012 published a paper in Alcohol Clinical and Experimental Research in which she looked at data on 992 children prenatally exposed to alcohol who were prospectively collected from 1978 to 2005 through our program, the California Teratology Information Service. Passive timing of alcohol exposure in relation to features of FAS were examined. These examinations were performed blindly by one examiner, and that was me. Passive drinking were evaluated by drinks per day, number of binge episodes, and maximum number of drinks. And the time of exposure was evaluated as follows. We looked at 0 to 6 weeks post-conception and 6 to 12 weeks post-conception. So we split the first trimester in half, and then second trimester and third trimester. And the selective outcomes that we looked at were short palpebral fissures, smooth philtrum, thin vermilion border, microcephaly, birth length, and reduced birth weight. And here are the results of that study. The number of binge episodes and average daily drinks per day during the first trimester were significantly associated with all outcomes except short palpebral fissures. However, the strongest effects were in the second 6 weeks post-conception, so 43 to 84 days, or 6 to 12 weeks for a smooth philtrum, the thin vermilion border, the microcephaly, and reduced birth weight. The strongest effects in the first 6 weeks, so 0 to the 42 days, was for reduced birth length. The only significant association for head circumference was with first trimester exposure, and the short palpebral fissures were significantly associated with any pattern or timing of alcohol consumption, but approached significance for the maximum number of drinks consumed on one occasion during 6 to 12 weeks gestation. So this just shows you possible explanations for the disparity between the human and the mouse critical timing. Remember, the mouse was 7 gestational days, which is the end of the 3rd week to the beginning of the 4th week in human pregnancy, and our possible explanations are that the gestational window of 0 to 6 weeks in our study included first weeks post-conception, which is all or none period, due to misclassification of embryonic exposure during the 0 to 6 week period. The estimate of the effect could have been biased, Secondly, we included only live births in this study. Infants exposed during weeks 0 to 6 who would have exhibited physical features could well have been spontaneously aborted. But the other possible explanation is that it could be that the critical period for development of some of the facial features in humans is in fact the 6 to 12 week window, as opposed to the end of the 3rd week to the beginning of the 4th week of development. Let me talk a little bit about successful prevention strategies and successful intervention strategies. And what you ought to realize here is this, and that is that and this is where I get back to the issue that for many years we were, I fear, asking a lot of questions that I think were important, but I think the time has really finally come to start looking, to get this ship turned around, if you will, and start looking at the things that are really relevant as far as this condition, and that's prevention of it and intervention for those children that have it. And I want to point out that the first International Conference on Prevention of FASD did not occur until 2013, September of 2013. So it's a little bit less than 2 years ago. So in fact, we are only started to look at these issues of prevention, and we've been looking at, I say we, people have been looking at intervention for a while. I'm just going to skip this. I would tell you that this is a thought of preventing this disorder really a major thing to get over, because there is so much drinking that goes on in the United States and really throughout North America, and really, I would say, throughout the world, by women and men, obviously, who are not pregnant. And the first 6 weeks of that pregnancy is a period of time which you all know a woman does not recognize she's pregnant. And so the result is that for at least the first 6 weeks, a woman is often drinking quite a bit of alcohol, and that, of course, is a very critical time. So let me talk about some prevention programs that are already in existence. And so Surgeon General's warning here in the United States, warnings on cans and bottles and warning signs and bars and where alcohol is sold. And as you well know, those two things have been pretty worthless as far as, or not worked very well, as far as changing women's drinking and preventing this disorder. A brief intervention, motivational interviewing, and project choices, I think, have had a lot of benefit as far as this is concerned. And of course, the choices is that you don't drink during your pregnancy, or you use effective contraception, and of course most women opt for effective contraception, and unfortunately effective contraception doesn't always occur. Contraception might, but not necessarily effective contraception. But I think that without question this has worked to a certain extent. I just want to mention something which is a little bit tongue-in-cheek, but it really has gotten a amount of play, and that's this pregnancy test dispenser. And you see here, alcohol consumption while you are pregnant is a definite no-no in modern society, but what if you didn't realize you were expecting? If you're in the vicinity of this Minnesota bar, there's no excuse. Pub 500 of Minnesota has installed a pregnancy test vending machine so you can get your results before ordering a drink. So you see step one, you go in, these are in the bathroom, in the ladies' room, and so you swipe your credit card, you then make a selection, and then you remove the pregnancy test. You test yourself to determine whether you're pregnant or not, and then you can go back in the bar, and if you test positive, of course you don't drink, and if you test negative, you can feel comfortable drinking. Now, I've talked to a number of people about it, and I must tell you that most women think this is ridiculous, but there are a large number of women, I think, throughout North America who are feeling very positive about this, and I think that there's a possibility, at least, that this could catch on throughout the country. And then finally, just let me say to make people aware, and it is just amazing, and I go back to autism for a second. Everybody knows about autism, and very few people are really aware of the fetal alcohol syndrome. People, I think, know that you shouldn't drink during your pregnancy, but they really don't know why. They don't really know that this is really the number one cause of intellectual disability in the Western world, preventable cause, certainly, of intellectual disability. So we need to do our better job of making people in the lay public aware of this disorder, and we also need to do a far better job of making the medical profession aware of this disorder. So now let me say something about intervention. And there has been a lot of work done on intervention of this disorder. There are animal studies which have suggested that giving choline supplements in alcohol-affected helps improve learning and memory, and there are a number of trials in children going on now from 3 years to 10 years on going to test the benefit of choline supplements in children with an FASD, and some of them have been completed and others are still in process. So this is something that has really worked amazingly in animals, which is now being evaluated far more closely in humans. This is something that we have started here in San Diego. It's the Institute for Fetal Alcohol Spectrum Disorders Discovery. It's a dedicated multidisciplinary diagnostic clinic and follow-up program that focuses on the specific needs of the child and the family, which we have started here at UCSD Rady Children's Hospital, and it's been going for about 3 years at this point. I will admit to you sheepishly that I have been looking at children and evaluating children with the fetal alcohol syndrome for 40 years here at UCSD, and it's been sort of a disgrace from my part, I fear, because what I have done is evaluated the child and then said to the mother, I think your child has the fetal alcohol syndrome, and she says, okay, I thought that, and what do we do? And I said, well, I don't know. There's nothing to do. I'll see the child again in 6 months. And of course, this was a totally irresponsible thing, I think, for me to do. And so we have started this program. I have to admit that Chambers, who introduced this today, was to a very great extent responsible for doing this. So we've developed this multidisciplinary diagnostic clinic now that focuses on the needs of the child and the needs of the parents, and we've got a number of other subspecialists involved in this, and I think it really, unfortunately, it's a tough thing to do, but I think it's the answer to dealing more appropriately with this condition. And we've been screening special populations. We've been working particularly in the juvenile justice system. It's a pilot project which we initiated in August of 2013 in collaboration with the county probation department and then public defenders, and its screening is offered to children admitted to juvenile hall whose families consent. And I have trained a nurse practitioner to look at physical features and to also do a neurobehavioral screen. And if the children screen positive, then we see them in our multidisciplinary clinic. And then let me go back here. And they have a parent support group, which I think is doing really been an incredible thing for mothers who can just learn an incredible amount from talking to their mothers who have kids with this disorder. And then we do a huge amount of community education and training. So let me go on now and talk very briefly about the effect of low to moderate alcohol exposure. And I must tell you that it's surprising to me to a great extent that people are so obsessed with drinking alcohol during pregnancy. They would never say, well, can I smoke one cigarette a day? But they do say, can I drink one glass of wine a day? And in the third trimester, can I drink a little bit of wine? And so forth and so on. And there have been now a number of studies that have been done looking at the effects of low to moderate alcohol consumption in early pregnancy. And the ones that I've listed in yellow here are studies that have shown that, in fact, there seems to be no effect of low to moderate alcohol consumption in early pregnancy. The ones in white have shown a positive effect. Most of the studies, as I said, have shown consistent negative effects of low to moderate alcohol intake in early pregnancy on socio-emotional difficulties, behavioral problems, mental health problems, attention and learning, and executive functioning. Many of these studies have shown that low to moderate alcohol intake is associated with an increase in child's IQ relative to non-drinking mothers. And it's interesting the gender differences in child mental health in some studies of low to moderate prenatal alcohol exposure has shown that with girls at higher risk than boys for problems due to low to moderate alcohol consumption. So there's some limitations to this study. First of all, there's retrospective recall of drinking during pregnancy, and the documentation of alcohol consumption in these studies is sometimes 9 months after the fact. The presence of drinking and the peak blood alcohol levels play a key role in determining the risk. 4 drinks on an occasion is higher risk than 1 drink per day for 4 days. So binge drinking is really the critical amount of drinking as far as this is concerned, and that was very poorly documented. And then levels of drinking vary with social factors. So with light drinking, it might not be the drink, but who's drinking it. Light drinking is associated with older, better educated non-smokers from higher income households. So there are a number of limitations to this study, and I must tell you that I really think that the best approach is not to drink anything during your pregnancy. Now I want to say a few words about genetic factors because I think that they are critical issues. So this, again, is a question that I think desperately needs to be answered. This is the way alcohol, or the vast majority of alcohol, is metabolized. ADH, or alcohol dehydrogenase, converts alcohol to acetaldehyde, and then acetaldehyde to alcohol. Uses LDH, or acetaldehyde dehydrogenase. And so there are genetic polymorphisms that clearly impact, we think, on the risk of FAS in humans. So ADH, unlike LDH, has a number of polymorphisms. The isoenzymes, which are encoded by those polymorphisms, have the ability to metabolize alcohol. Because some ADH-encoded isoenzymes have significant differences in their kinetic properties, it's been suggested that some ADH alleles have a great impact on the rate of alcohol metabolism. And so these are 4 ADH polymorphisms that have been shown to impact the risk for the fetal alcohol spectrum disorder. ADH1A, which is expressed in the first trimester of fetal life, less active later in gestation. ADH1B, which is active in the liver from the second trimester and gradually increases in activity. ADH4, which is expressed in the liver from the second trimester and is important at intoxicating levels. And ADH7, which is expressed in the stomach mucosa, it acts early to metabolize alcohol before it reaches the blood. So the genetic variation in offspring in terms of IQ score is showing here. The following 3 genetic variants in alcohol metabolizing genes were associated in children with decreased IQ at age 8. So rare alleles at ADH1A, a rare allele at ADH1B, and a rare allele at ADH7. The effect was seen only in the offspring of mothers who drank moderately during their pregnancy, and when the mother's genotype was entered into the model, ADH4 was also associated with her child's IQ at age 8. So just our hypothesis as far as this is concerned is that metabolic activity of some ADH alleles result in higher levels of the noxious and unpleasant metabolic intermediate acetaldehyde. Women possessing these alleles drink less and thereby do not attain as high a blood alcohol concentration, reducing the risk of FS. Conversely, women who carry genetic variants that decrease metabolic activity result in low levels of acetaldehyde, lead to increased drinking, and they thereby attain a higher blood alcohol level, increasing the risk of FAS. And with something else that I think is incredibly important, and that's nutritional factors. And this is a study that I'm going to show you is a study which is an ongoing study. It's being done. It wasn't initially being done in Russia. It's now being done in Ukraine. And the PI of this study is Christina Chambers, who's moderating this section. It's a prospective cohort study involving 300 moderate to heavily exposed pregnant women recruited from ladies' consultation, prenatal care centers, and 300 low unexposed comparison women in Ukraine. So this is specific aim 1 of the study. It's to measure the incidence and spectrum of alcohol-related birth outcomes in relation to dose and timing of alcohol. So these women get standardized, repeated in-person maternal interviews supplemented by biomarkers of exposure. They have standardized physical examinations by specially trained neonatologists, geneticists, and neurobehavioral testing at 6 months and 12 months with Bailey tests and infant stimulus response testing at 6 months. So, aim 2 is to assess the contribution of nutritional status and effective nutritional intervention trial initiated in mid-trimester. So blood samples are taken at enrollment and at the 3rd trimester and are evaluated for vitamin and mineral status. Multivitamin mineral supplement is provided for 50% of the sample upon enrollment, and an additional choline supplement is provided to 25% of the sample upon enrollment. Here are the specific aims, or the results of specific aim 2. Specific maternal micronutrient levels in pregnancy vary by maternal dose of alcohol. Specific maternal micronutrient levels in pregnancy are significantly correlated with cardinal facial features and growth in alcohol-exposed affected children. And finally, minerals and vitamin intervention initiated in mid-gestation appears in preliminary analysis to have a protective effect on some alcohol-associated neurocognitive performance measures and growth in infants in the first year of life. Now, this study is now continuing, and the plan is to continue to study these children with the same measures throughout the first 5 years of age, and then follow them, hopefully, through adolescence to see if these effects on neurocognition and growth continue. So this is my last slide, and I just want to sum up this by saying that I must admit that at the present time I'm quite optimistic about where things are going as far as this disorder is concerned. It's really been a struggle. If you can think about it as every year, and you look back over the last year and you think to yourself, well, what has been accomplished over this last year? But when you look back over 41 years, it's pretty amazing, I think, that people have come this far in terms of better understanding this disorder, and that now we are focused far more on prevention and intervention strategies for children and their families with this disorder. So thanks very much.
Thank you, Ken. With that, I think we're going to open up the audience for questions. We have, I think, some people who are on the audio portion of this and may ask a question over the phone. So for the few people that are listening to this audio, I'm going to actually read one question that came in via the web first, and then we'll move to anybody who wants to ask a question over the phone. So again, I don't think you can see this, but the question that came in says, I work for a program called Welcome Baby in the state of California, and we serve pregnant women. So my question is, if the client discloses that they're drinking past the 13th week of gestation, is this reportable?
Reportable from the standpoint of the law, I'm assuming, and it's not.
I'm assuming that's the question.
Yeah, no, definitely is not. And I would suggest that really perspective anyway, and I think from the perspective of most of us that are dealing with this would really be a very negative thing to do, because I think that if women who have a problem with alcohol and are continuing to drink during their pregnancy, if they were the impression and believed that they were going to be reported for this to the law, that they would simply not report it to anybody, and therefore they would not get adequate prenatal care, et cetera. So definitely it's not something that's reportable in the state of California at this point.
Any questions from those who are actually on the phone for the audio portion of this? If none, I will go to some other questions that have come in via the web. Next question is, which maternal micronutrients have been shown to be significantly correlated with cardinal facial features of FASD?
Well, I'll answer this first, but then I'm going to turn this back to the moderator, Dr. Chambers, who really has done this study. The thing that has amazed me, as far as the study that's being done in Ukraine is concerned, that the vitamin pill, the vitamins that have been supplemented are a common vitamin that sold in drugstores in Ukraine and really throughout the United States as well. But Tina can give you some more information about specifics as far as vitamins and minerals. Will you do that, Tina?
So just briefly, in response to the question, there's two issues here. One that, of course, vitamin and mineral status of women at the time that they enrolled was wherever they were at, irrespective whether they were taking vitamins on their own or what their diet quality was like and so on. But since women enrolled mid-pregnancy, the assumption would be that the cardinal facial features would probably have already been either present or not present at that time. That being said, there has been some indication in preliminary data that folate levels and iron levels in moms mid-gestation seem to have some association along with the amount of alcohol consumed with cardinal facial features. So next is, can you talk a little bit more about the diagnostic tools to diagnose FASD? You mentioned the 1996 OM guidelines, but what about something like the HOIMI revised guidelines?
Right. Well, to be honest with you, that's what we use. We use here in San Diego and in most of the studies that we're doing, well, all the studies that we're doing abroad in Ukraine and that we did in Russia and that it's going on in South Africa and here in the United States it's going on in Atlanta, Georgia, and here in San Diego and in Los Angeles and Minnesota. We use the revised HOIMI criteria. So we, as opposed to a number of other criteria, for growth, we use linked weight and head circumference equal to or less than the 10th percentile, as opposed to less than the 3rd percentile. We look, again, as opposed to some other studies, we look at palpebral fissure length equal to or less than the 10th percentile, again, as opposed to less than the 3rd percentile. And then we use the Ashley Claren picture that shows the philtrum and vermilion border of the upper lip, which we then categorize as 5, 4, 3, 2, or 1, and 5 being the picture of the philtrum and the vermilion that is most smooth, the philtrum that's most smooth, and the vermilion that's thinnest and smoothest. We use 5 and 4 for the fetal alcohol syndrome, so we use those criteria a lot as far as looking at the face. And I would say that we use equal to or greater than the 10th percentile to cast a little bit wider net, and also because we believe that studies that we have done, we believe that one would miss a number of children who were prenatally exposed to alcohol, who clearly were affected by alcohol, who had palpebral fissures and length and weight and head circumference that were between the 10th and the 3rd percentile. So we would miss them if we just depended upon the 3rd percentile. So that's what we use at the present time, and other people use slightly different things, but I think that the important thing is to have the numbers available so that you can look at the numbers that you've got based upon any category, and anybody can use those numbers to determine a prevalence figure as opposed to just to not providing that. So that's how we do it.
Okay, and one of the people on the webinar has the question, could you explain choline?
do that for me, Tina, please?
I think this questioner, I think, is probably maybe asking what choline is. So choline is a B vitamin that's present in many foods and is thought to be important in brain development. And if this is probably beyond what the question was, but there are logical reasons to think that it might have a beneficial effect on the types of areas of the brain and brain functions that are affected by alcohol, and that's in fact what's been demonstrated in the animal model. Because this is a micronutrient that is part of the normal diet, that's one of the reasons why there's intense interest in the potential for using this as a treatment that may actually ameliorate some of the effects of alcohol that have already taken place. So next question is, and this goes back to the issue of problems with the baby that was asked before if the mother drinks and legal issues. So from Canada, here in Canada, we have to call the local Children's Aid Society to report, and they decide how to move forward. Usually the baby is apprehended at birth as the mother has already has been flagged. I assume that means already been flagged as a substance alcohol abuser.
Well, very interesting. We do not have that in California, that requirement in California. I really, I think the important thing, obviously, and it sounds like you're doing this in Canada as well. It's not that just because a woman is drinking past week 13 that she's going to have her child taken away from her, but rather the mother and the child will be evaluated at the time of birth, and depending upon what the mother's situation is, some kind of a decision will be made as far as that's concerned, and that obviously occurs in the United States as well. And that, I think, is really an incredibly important thing to do. But I think the concept that a woman who drinks a glass of wine or even a few glasses of wine in the 20th week of her pregnancy is meant to be evaluated from the standpoint of alcoholism and potentially sent because somebody's concerned that she's going to be a bad mother and have problems with her baby. That seems a little bit extreme to me, but maybe I can understand why that happens. But I hope we take a different approach to that. We take the approach that it's more important that a woman feels comfortable and does, or let me put it this way, that a woman is not feeling that the law is going to get involved in this because we believe that will cause her not to come in for adequate prenatal care.
So we had actually a question or a response, a comment come in response to the previous question and answer about choline, and this is the comment. The attendee said that choline has been shown to be protective in folate deficiency. So she's bringing up in the discussion of choline is that this is part of this whole methyl donor pathway that involves B12, folate, choline, and methionine and metabolite, and they all have a relationship with each other, and certainly deficiency in one may impact another as well. And so that brings up the issue that if we know that folic acid is important for a lot of developmental processes in pregnancy, and the relationship between choline and folate may be important in prenatal alcohol exposure as well. I think we have time for one more question, and the last one is could you please explain the main differences between FAS and FASD?
FASD is really the total spectrum of abnormalities that result from prenatal exposure to alcohol. So FASD is not a diagnosis. It's sort of a descriptive term that describes this spectrum, that on one end of the spectrum is the full-blown fetal alcohol syndrome. So a child with growth deficiency and microcephaly and palpebral fissures and a smooth philtrum and a thin vermilion border of the upper lip and neurobehavioral problems. At the other end of that spectrum is alcohol-related neurodevelopmental defects, and that's children who have been prenatally exposed to alcohol who have these characteristic neurobehavioral problems. And in between are children who have partial features of the fetal alcohol syndrome and other children who have birth defects that we think are related to that, and that's called ARB, or alcohol-related birth defects. So FASD is this entire spectrum of defects that are associated or resulting from prenatal exposure to alcohol, and FAS, or fetal alcohol syndrome, is the most severe end of that spectrum.
Thank you very much, and thank you to all who attended. I think the remaining questions were focused on whether or not people could access copies of the slides. And unless Heather wants to make another comment, I think the best approach to that is to go to the website, teratology.org, and information about the recording and the slide presentation itself will be made available there. Unless there's any other comments. Heather, did you want to make a comment regarding that? Can't access this by phone. So thank you so much. We will post information on the website about access to the seminar. Thank you for attending, and thank you, Ken.
Thank you.
Bye.
Bye.